Well, good morning. It's 7 o'clock, and I think we'll get started. I'm Val Lewis, and on the behalf of the Education Committee and the ISOLS organization, I want to welcome everyone to March's webinar. We have a fantastic webinar prepared for you today. Dr. Hairong Xu of Xu Sui Tan Hospital from Beijing, China, has organized a great speaker list on giant cell tumor medical and surgical treatment. I just want to remind everyone that the webinars are held the third Tuesday of the month. Next month, we do have Dr. Weingarten, and he's prepared a great webinar on revision and megaprosthesis reconstruction. So at this time, I'd like to hand it over to Dr. Xu and Dr. Zumárraga, who will introduce today's speakers. Thank you.
Well, thank you very much, Valerie, and thank you very much, Dr. Xu Hairong, for this webinar. So I guess we can start with our first speaker, which is Dr. Kwok-chuen Wong. He's a consultant from the Department of Orthopaedics and Traumatology from the Chinese University of Hong Kong, China. So if you may, please, Dr. Wong, you can start.
Okay, thank you for the kind introduction. Let me share my screen first. So can you see my screen?
Yes. Yes, we can.
Okay. So thanks for the kind invitation and the opportunity to share the topic. I'm concentrating on the biomolecular pathogenesis of giant cell tumor bone. That's important for its proper treatment. So I have no disclosure. So I'm going to share with you the pathophysiology of a giant cell tumor bone, what we know about the stromal cell, and also the mainly concentrate on the medical treatment and what the evidence help us to guide the treatment strategy and have a conclusion. So giant cell tumor bone actually is very common in the Asian population, 20% in primary bone tumors in China and less in the overseas countries. They have characterized with extensive destructive just articular bone destruction around the just articular joint. So I think this is a classic histological slide of a GCDB, consists of three types of cells: stromal cell, monocyte, and osteoclast. But how they interact with each other in the molecular level and the tissue levels. So before we go to the pathophysiology, we should understand what's the normal bone remodeling. The most important of the key cell is the pre-osteoblast. Actually, it triggers the osteoclastic differentiation and increase the bone resorption. And this is heavily regulated to avoid excessive bone resorption by the mature osteoblasts with OPG decoy receptor for the rank ligand that actually control the bone formation. The problem of giant cell tumor bone is there's an excessive increase in this pathway with the rank ligand pathway. So as a result of this stromal cell actually is overactivated. It's the neoplastic component that actually attract the monocyte from the bloodstream that go to the tumor site, that causing for formation of a multi-nucleated giant cell. And this multi-nucleated giant cell actually implement all the lytic destruction at the tumor site areas. So what actually we know about the stromal cell? Some would postulate from some of studies that actually it's a neoplasm with a cytogenetic alteration. The histone gene mutation now is very frequent in this. There's some postulation of the neoplasm for this stromal cell. So stromal cells, because of no cytologic features of malignancy, something that's just a reactive condition. But I think, and now in the current evidence that actually, I think that the stromal cell with the current evidence is a pre-osteoblast, the one I mentioned in the normal bone remodeling areas. You can see on this slide, actually they are quite resemble with the mesenchymal stem cells. And evidence is showing that they express marker of early osteoblastic lineage. So actually it's a pre-osteoblast, but somehow they are arrested in this stage without the normal regulatory mechanism for the bone formation. So for bone metastasis, for the histology-wise, there's no malignant cytologic features, rarely discovered at the initial diagnosis, more up to the local recurrence, and most within the 3 years after surgery of the initial treatment. So that's why some will postulate that actually it's the mechanical type of a bone, the tumor embolized to the lung area. But some medical oncologists saying that maybe the the biology of the tumor that actually predisposed to this pulmonary metastasis, and at the same time prone to local recurrence. So we have quite evidence that the stromal cell actually is overexpressing this rank ligand pathway. And then one of our study from my institute is that actually we find that there's a transcriptional regulation, the rank ligand promoter. The protein binding this promoter is upregulated in this pathway, and then making a postulation, this stromal cell actually overexpress rank ligand. So I think the treatment for the giant cell tumor bone with additional medical treatment, because it's a benign tumors. So the first is still reduce local recurrence, because benign tumor we want to preserve function. So the strategy is, of course, we need to tackle the neoplastic part. Either you kill anti-tumor, kill the neoplastic cells, or make it a good guy, promote differentiation because of pre-osteoblast state. Others is you against the effector cell. Either you kill it or inhibit the formation. So that's why in the past there's some drugs that can inhibit this kind of neoplastic component and also the resorptive part. So bisphosphonate, zoledronic acid actually is very been used for quite a long time for anti-resorptive agent for bone metastasis and also porosis. And they have they act on tissue level. They have a high affinity to the mineralized bone, especially at the site of high bone turnover, and also have a effect of inhibit the osteoclast proliferation, induce apoptosis, also enhance the differentiation of this osteo to forming of the osteoblastic mature osteoblasts. And then in individual study, they have anti-cancer effect in all other kinds of carcinomas. So the denosumab I've talking about in the last 10 years. So it basically is target to the rank ligand pathway. So it's a very potent, effective on this pathway to stop all the resorptive activities. I think this slide actually compare the two drugs. So I think the main difference between the two drugs is denosumab is very target, very potent. They just kill off all the osteoclasts, but they don't have any effect on the tissue side. But of bisphosphonate, they are less potent. They also inhibit the osteoclastic activity. They just block all the remodeling site. So at the end effect is that the denosumab is more potent. They got a shorter effect because they don't have a tissue action. But bisphosphonate is less potent as compared to denosumab, but they have a longer effect because they stuck to the block all the mineralized area in the tissue level. So, for example, for this case with a young girl with a GCTB, with one dose of zolmida, you can appreciate there's a lot of necrosis around on the fibroblastic tissue there, and also there's a negative G34W protein staining. And then with the current evidence for the zoledronic acid on GCTB in the preclinical studies, so actually you can show a dose-dependent effect on the anti-tumor side. And in the actual clinical study, actually you can also show similar effect in the cell culture. Cell necrosis also inhibit the osteoclastic activities. There's some increase in bone formation, so that there's a postulation that where these drugs can actually promote the differentiated stromal cells. So also there's a one meta-analysis that have included a few studies with a case control manner. So they find that at early follow-up, bisphosphonate can actually reduce local recurrence in this GCB with intralectional curettage. So for one of our early case, if stage 3 GCT, we just curettage the capsule, and then we find that after the 3 dose of zoledronic acid, it actually caught a very good calcified shell for this case. But non-efficacious can be like this distal radius 2 years later, after curettage cementation with a post-op zoledronic, it recurs locally. And then 6 years another recurrence. But we find more pretty sure that whether it's actually decrease or delay or decrease aggressiveness or local recurrence, what is the long-term result of this we still don't know. We are looking at our data later on. So it's very logical to see whether denosumab have the same effect on the stromal cell. So in this stromal cell studies, in cell culture cell line, we find that zoledronic acid got a dose-dependent anti-tumor effect. But denosumab, in all sense, they don't have any anti-tumor effect. So at that time, we already suspected that if we stop this drug, actually the tumor will grow back. So later on, further confirmed by a Canadian group, they showed that after 6 months of denosumab in some of the GCTB, so they gave off a lot of all the giant cell activities, but the stromal cell is still there. So in this bigger series, they also confirm there's a presence of a stromal cell, but they are in a zonal pattern that the tumor is still on central, the periphery is forming of osteo surrounding all this stromal cell, and they don't have any effect on the differentiation part, and because of all this increase of osteoclastic activities, they have shown that they decrease the proliferate index and also the angiogenesis part. So we work with a professional group that in the pelvic and sacral GCT, we find that they can decrease the blood supply. And also in CT scan, histology and CT scan, they show there's a decrease in angiogenesis and also decrease in microvessel density. That make our suggestion that for pelvic or sacral tumors, sometimes this drug can decrease the blood loss. So it further confirmed that this denosumab in Vaishali Institute that actually for curettage part, it actually increased the local recurrence and also don't have any effect on the decrease in the risk of lung metastasis. So that means to make your curettage more difficult, but at the same time can't change the biology of the tumors. So in this case, after denosumab, basically all the stromal cells there, you can see that it's fibrotic rectus tissue. It's very difficult to curettage and not sure whether you have cleared the rim or not. So it summarized the cellular cell culture and the histology. So on the preclinical study, we demonstrate that there's no anti-tumor or any promotion effect of the osteoblastic lineage of the stromal cell. And the clinical study for histology-wise, they can somehow decrease the stromal cell activities. But why this can be done, and we don't know. We suspected that they may indirectly modify the local bone environment that indirectly inhibit the activity of these stromal cells. So there's a lot of controversy of denosumab, the timing for surgery, the time for local recurrence. I think one of the information we can get is from pharmacokinetic response to denosumab 60 milligram subcutaneous injection. Let's say for denosumab, we know that there's no anti-tumor. There's no anti-tumor effect. The effect is only the anti-resorptive part. So if we want to get an intracranial curettage for the maximum for the anti-resorptive activity, it should be somewhere around 1 month. And then if you want to sort of resection with a calcified rim for E0 resection, so probably is within the 6 months, because you see that the bone mineral density after 1 dose of denosumab is increasing. And then after 3 months, actually you should see that the resorptive activities increase again. That means that the tumor will recur. So with that, unresectable tumors, whether we can treat it as a chronic disease with decreased dose intensity schedules. Lung metastasis, because there's no anti-tumor effect, so mainly on the osteoclastic activities. So it could show the control of the lung metastasis, but you need to remove all the stromal cells. You still need a resection if it's still resectable for lung met. So after 3 dose conservative denosumab, after stopping 3 months, it come back. So one of the issues is after denosumab, it's really difficult to curettage. In this case, like the ischial GCT 6-month denosumab is actually hardened. It's very difficult to identify intraoperatively. One of the issues is they form some additional calcified septa. We find sometimes it's really difficult to identify at the bottom. So that's why in some of our cases, we use a navigation to assist the burring to clear the tumors, and also put a scope inside to make sure that we clear everything. And then because of the anti-tumor effect for curettage, we postoperatively we give 3 dose someters. So this is one of the study we show after this previous study on the stromal cell part, whether any medical drug that can have both anti-tumor effect and also differentiation promoting properties. And then we find that this simvastatin, actually this anti-cholesterol drug, actually have an anti-tumor effect as well as the promote stromal cell proliferation. With RNA sequencing of all the some of the stromal cell sequence with our informatics, we postulate it actually is upregulating the vitamin D pathway, and somehow it concurs with the tumor. Actually, we saw in India they have a high prevalence of vitamin D deficiency. They got a huge chance. Whether it's related or not, I'm not pretty sure. So at the end, because of all this evidence, we find that instead of using the drug to see what's the treatment strategy, we find it initially should be have an intention to treat, whether you got a resection, curettage, or inoperable, before you decide what kind of drugs you are using for that. And also one of the consideration of the patient, whether they accept morbidity or complication of the reconstruction. Here, my last slide that what's a current indication for denosumab and Somita in our institutes. And then given that because this is still an adjuvant cannot kill all the tumor cells, it cannot be replaced as surgical tumor removal. The problem is how we identify and remove stromal cell during the curettage, whether we can modulate the drug regime so that we can monitoring the bone resorption. I think with that, on behalf of the group, I thank you for your kind attention. And welcome for your, love to hear for your comment and question. Thank you.
Thank you very much, Professor Wong. And now I'm going to hand it out to Hairong and Valerie to see the questions that we have.
Anybody have questions, you can ask Dr. Wong, or you can type your questions in the section of the discussion part. I mean, for the audience, you can write down your questions if you have any, okay?
So may I ask one question for you? Yeah, because Zumárraga and denosumab have a different mechanism, I mean, for a limitation of the giant cell tumor. And so it's a totally different, but both of them got the effect. So even with some shortage of the denosumab, they could not kill the stroma cell, but still they can limit the growth of the giant cell tumor. So but what about if we do the combination with these two drugs to treat the giant cell tumor? I mean, in the future. So what do you think of the future of this if we use this both bone target drugs for the one tumor? Thank you.
Thanks, Paul, for the comment and the question. In the past, we only tried 1 or 2 cases of a combination of this. Because initially we have a cycle GCT with a curettage and a Somita. We give 6 doses of Somita afterwards. It controlled quite well for 1 or 2 years, but later on we recur. We give Somita again, it control a bit. Later on, it just grow. We cannot control. And then at that time, we go give denosumab. It have a good control of the osteoclastic activity. And then later on, it just consolidate. So whether this combination of these two drugs, I personally, I don't know. But theoretically, they combine the both potent effect of the denosumab at the same time with the zoledronic acid. They can have some anti-tumor effect and also block all the resorptive remodeling area. That to a certain extent protect the bone area from further growth of the tumor, further destruction of that. But personally, I think we should target for one drug that can have a both effect at the same time. Yes, not sure whether I can answer your question or not.
Thank you.
Perhaps we could go to the next speaker because I do not see any other questions in the chat.
Yes, now we're going to ask Professor Ajay Puri to start with his presentation. Professor Ajay is the chief of the Orthopedic Oncology for Surgical Oncology at the Tata Memorial Center and Homi Bhabha from the National Institute of Mumbai, India. So please, Professor Ajay.
Thank you, Pablo, and good day, everyone. Now, J.C. Wong has made my job a lot easier. He's either, it depends on what way you look at it, he's laid the foundation for my talk, or he's already actually taken half my talk for me. So when denosumab first came into the market, we all thought, wow, this is the magic potion. This is going to solve all our problems in GCT, and that's not something we're going to have to scratch our head about. But as time passed and we learned more with our experience with denosumab, we realized that it was not all hunky-dory. There were issues with denosumab, and we needed to look at it a little deeper to understand how best we could use this drug. So with the increasing years, now we have a fairly decent idea about what we know about denosumab and what we don't know. Currently, I think there is consensus more or less on the fact that denosumab is not going to be used for all cases of GCT. It's selective in its use. A case like this, which is very easily curatable, we are not going to recommend or use denosumab. A case like this, yes, we will have our sort of differences of opinion. Some may say that we could curate this without denosumab. Some may say go ahead and do a resection. And some would say that possibly we would give denosumab so that we have a scaffold against which we could curate better and save the proximal humerus for better function. As Casey has shown, denosumab needs to be followed by surgery. Denosumab is not an alternative to surgery. A case in point, December 2013, a giant cell tumor of the pelvis. We gave denosumab and it responded beautifully, and you can see the ossification. The patient thought he was wiser than us in spite of us recommending surgery because all symptoms had subsided. He decided he didn't want surgery, stopped denosumab, and lo and behold, this is what happened, back to square one. We have also learned that if we are going to do a curettage, it is easier if we operate as early as feasible. That means the moment we start seeing a response to denosumab, it's best to go down and do our curettage at that time, because the longer that we wait, you will have more of an ossific rim, and it could be difficult to differentiate between what is normal bone and what is abnormal tissue. We also accept the fact that recurrence rates are higher with denosumab usage. But here there is a little bit of a debate. Are we being unfair to denosumab? Can we compare this to all comers of GCT and then balance recurrence rates? Or are we giving denosumab only in those cases in which there is potentially a much higher chance of recurrence? So can we actually blame denosumab for the recurrence, or is it that these cases inherently would have had more of a chance of recurrence? This is a case in point, a giant cell tumor of the distal radius. Normally, possibly, we may have resected the distal radius, knowing that the distal radius is more prone to recurrence, etc. We gave denosumab and were able to do a curettage. But a few months later, there was recurrence, and then we finally did a resection and an iliac crest bone graft and arthrodesis. So was this a case that we can actually blame denosumab, or we tried pushing our luck and therefore recurrence came back? So this has been captured quite elegantly in the recent paper by the Toronto group that have said that when you use neoadjuvant denosumab for these so-called joint sparing procedures, we need to balance the higher risk of local recurrence but improve function if we are doing joint salvage, vis-a-vis the lower risk of local recurrence but the potential morbidity if you were to do a resection. So I think the jury is still out as to whether we can blanket say that denosumab increases the rate of recurrence in all cases. Is there a role of denosumab post-surgery? And I think most have decided that when you're doing surgery, denosumab added post-surgery really does not add too much of a benefit. So what is the future? What are we looking at? What do we now still need to answer questions about denosumab? And the first is, most of us, in fact, all of us have used the initial dosing that was described in the initial paper about denosumab being given 4 doses in the first month and then 1 every 4 weeks, because that was how the paper described it. Is that mandatory now? Can we reduce the initial dosing? Can that be modified? A point to consider here is this paper by Professor New's group, which Casey already referred to, that denosumab also works by reducing the microvessel density and thereby reducing the blood supply of the GCT, especially in sacral and pelvic lesions. So if we are planning a curettage and if we decrease the initial dosage, will that mean more bleeding, less adequate curettage in those areas? Questions that need to be answered. The question that Professor New asked after last talk, is there a role for denosumab in combination with other modalities? We know that zoledronic acid has actual inhibition of the cell growth of neoplastic cells, but denosumab has no inhibitory effect on these cells. Can the two be combined, one given pre-op, one given post-op, or different combinations? The jury is still out because this multicentric randomized trial that talked about the adjuvant treatment using zoledronic acid versus denosumab showed that zoledronic acid did not decrease the recurrence rate of GCT. And therefore the efficacy could not be determined, possibly because of the sample size. So again, no clue as to whether we can use different agents in combination in GCT or not. Another paper by our group that spoke about large sacral giant cell tumors in which surgery, if done, would lead to considerable neurological morbidity in terms of possible loss of bladder bowel because of injury during curettage or a resection. So we used a combination of denosumab and angioembolization, which has been used earlier, and the few cases that did not respond, backed it up with radiotherapy. I know radiotherapy in a benign tumor is again controversial, but just as surgery has advanced, so has techniques of radiotherapy. And possibly the danger of radiation-induced sarcomas is not as evident now as it was maybe 3 or 4 decades earlier. So everyone may not agree, but this is one possibility. And we have been fairly successful in this. In our small series of 13 cases in which surgery would have caused considerable neurological deficit, we have been quite happy with the use of short-term denosumab backed with angioembolization. Another question that we need to answer is having some objective evaluation of the response to denosumab. All of us say yes, partial response, good response, but to be able to compare results, we need to have some objective criteria. And this article, again by the Rizzoli group, has given us a good idea how we can do a CT classification of the response to denosumab from 0, which says that there is an increase of more than 25%, to 2C, which talks about a reduction in size and ossification. The next point that we need to look at, if we are going to give prolonged denosumab, can we change the dose? Can we change the frequency? And what is the safety? Again, the initial group published a paper and they spoke that the interval between doses can progressively increase if there is adequate radiological response. But they did not reach any conclusion as to how much the dose can be reduced, what is the frequency that can be given, etc. And these are parameters that we will need to study. One of the biggest dangers or queries has been the malignant transformation of giant cell tumor when we use denosumab. We've had the occasional case reports that speak about this malignant transformation. And why do people have this doubt? Because rank ligand plays a critical role in the lymphocyte development and the lymph node organogenesis. And therefore, inhibition of rank ligand could possibly increase the risk of new malignancies. Also, rank ligand expression increases the level of nuclear factor 1b, which inhibits the tumor suppressive function. And therefore, restraint of this could lead to osteosarcoma carcinogenesis by raising susceptibility to the nuclear oncogene. So people have raised queries. But look at the largest trial on denosumab, which was 532 patients, and they identified 20 patients with possible diagnosis of malignancy. When they looked back at it, 15 of these malignancies were present even before denosumab was initiated. So we all know that giant cell tumor can undergo malignant transformation both with and without denosumab. And with the use of denosumab, the rates are consistent as that with previous reports. So I don't think this really has any merit today. We will have to wait for longer studies. What is the role of giant cell tumor in pulmonary metastasis? And this is a good article that talked about the progress of pulmonary metastasis, where they said that half the patients, even under observation, progressed and required treatment, especially lung nodules that were more than 5 millimeters in size. So what is the potential role of denosumab, either short-term to keep it under control or long-term prolonged in pulmonary metastasis, though rare, is something that we need to study. What is the safety of denosumab in children? We know that in children who are skeletally immature, the safety and efficacy has not been published. There is only anecdotal evidence. All studies of this have been on osteogenesis imperfecta, none on giant cell tumor. even though we have had anecdotal uses of giant cell tumor in young children. One of the cases from our institute, a 10-year-old child with neurological deficit, denosumab was used here because we thought any attempt at surgery, no neurological deficit, any attempt at surgery would have caused further damage to the skeleton. We used our combination of angioembolization and denosumab, and this has stabilized, and this is a 4-year follow-up. But in children, we need to be careful that you can have hypercalcemia even months after stopping denosumab, and therefore you need to be aware of that. Finally, what is the potential for the use of denosumab in other benign lesions other than giant cell tumor? And this is an interesting paper from the American Journal of Surgical Pathology that showed that rank L expression was there in 92% of chondroblastomas and 86% of aneurysmal bone cysts. So there could be a potential for using denosumab as a treatment option in these cases, similar to how we use it in giant cell tumor. A few case reports that spoke about denosumab in aneurysmal bone cyst. This is the pre-denosumab picture after surgery had failed, and after denosumab you can see how the disease has shrunk and stabilized. A similar case in the sacral area in an aneurysmal bone cyst where denosumab was used effectively. So now we have a fair idea about what we know about denosumab and what we do not know. And knowing what we do not know is as important as knowing what we know. So what is the potential solution to such problems or questions? It's obviously clinical trials. When you look at the clinical trials going on in denosumab, there is not really too much. Yes, there is the initial trial that is still looking at long-term safety and follow-up of patients with giant cell tumors, which is obviously not recruiting patients, but is still active, and hopefully this will give us a better idea about what are the problems if we use denosumab over a long time. We have this new trial which is recruiting that speaks about denosumab in subjects with giant cell rich tumors. That means the aneurysmal bone cysts, the chondroblastomas, the osteoblastomas. And again, this will give us an insight as to how we can expand the use of denosumab. But I think what is most depressing is the trial that we were all looking for, that how does reduced dose density of denosumab in unresectable giant cell tumors impact on that? And unfortunately, that trial has been terminated early because it did not accrue adequate enough cases. So I guess the only way we can try and answer these questions is by all of us getting together for a global collaboration. And I think ISOLS remains one of the best platforms that all of us can work on to try and see that we can put together studies in multi-institutional collaboration so that we get answers to these questions to benefit all of us and our patients. Thank you very much.
Thank you very much, Professor Ajay. And now I would like for Dr. Hairong Xu and Dr. Valerae Lewis to ask questions from the attendee.
We have one question from China. That is, how about the use of denosumab for the patients of adolescents? I guess his meaning is to ask the experience of your use of denosumab in children.
So, as I mentioned earlier, we do use denosumab in children, but it is a very, very extended indication. An example is the case that I just showed. Again, the dose is not similar to that in adults. It's a much reduced dose based on the weight of the patient. And this is where we actively consult with our medical oncologists, and it's under their supervision that this denosumab is given, because we know that there can be issues. In case the dose goes beyond a certain limit, you can have issues with the calcium metabolism. And as I showed, there are quite a few papers that actually spoke about this calcium metabolism being disrupted even 6 to 8 months after denosumab is stopped. So yes, we do use it. It's an off-label indication, but under very, very controlled conditions.
Okay, thank you, Dr. Puri. Actually, I have one question for you. That is, in your practice, do you use denosumab for adjuvant therapy? I mean, after resectable tumor?
No, we use a short course of denosumab only as neoadjuvant. We have so far never used denosumab after surgery.
Okay, thank you.
Dr. Puri, I have a question too. So what is your complication rate with the denosumab? Not necessarily from the orthopedic standpoint, but it's also associated with irritability and depression. Have you seen that much in your practice?
So no, we haven't seen that. Actually, it's the issue we have faced with denosumab is just been the difficulty in doing a curettage. And this was more so when we were using a longer course in the neoadjuvant setting. Once we have shortened our duration, we haven't, I mean, we've been a little better, not, I would say it's not become easier, but we've been a little more experienced and better. But apart from that, I think we have been lucky. We haven't seen the allied complications like osteonecrosis, jaw, or the other ones that you spoke of. And I think that is largely also because we use it for a very short time and a limited time and not for prolonged duration.
Great, thank you very much. We do have another question from the chat. It's from Dr. Raja Raman Sagar. And the question is, how frequently do you use denosumab and angioembolization for sacral giant cell tumors?
So as I mentioned, if the sacral giant cell tumor is S3 and below, that means we feel that we could operate on it fairly safely without ensuring any permanent neurological deficit, then we would treat it surgically. But if it does involve the nerve roots S2 and above, where we know that if it's resected, it's obviously permanent damage, but even during curettage, we can damage it, then we sit and have a chat with the patient, explain the pros and cons of it. And actually, it's the way we put it. Once a patient fears neurological deficit, then they all agree for the angioembolization and denosumab, and that's how we treat them. It's initial denosumab, then there is a window in which we do angioembolization, and then following that, we again go back to denosumab, and we reevaluate the patient with a fresh MRI every 3 months. Once it's stabilized, we stop. There have been cases in which we've had a resurgence or recurrence of disease, sometimes 6 months, 9 months down the line, and then we re-challenge them again.
Great, thank you very much. And there's one additional question.
Yeah.
It said, excellent talk, Dr. Puri. This person would like to know, how long should we wait after the last denosumab injection before embarking on surgery for giant cell tumor? And that was from Dr. Manchanda.
So normally it takes, as Casey has shown, it takes about 4 to 6 weeks for that denosumab to actually have effect. So giving a denosumab injection today and operating tomorrow makes no sense, because then the last denosumab injection that you have given really has no effect. So we wait a minimum period of about 4 weeks, and not preferably longer than 6 to 7 weeks, because then we can have resurgence. So it's that window between, say, 4 to 6 weeks when we would operate after our last denosumab injection.
Great, thank you very much. I believe that was the last question in the chat. So perhaps we can go to the next speaker.
Yes, well, our next speaker, it's Dr. Andrei Spiguel. He's an assistant professor in the Department of Orthopedics in the University of Florida, Giansville, United States. So please, Andrei, if you may.
Andrew, you should turn on your microphone. Yeah.
Yeah. Can you hear me now?
Yeah.
Now we can.
Yes.
Okay.
Yeah.
All right. So first, I'd like to thank ISOLS for this opportunity. It's a nice segue from Dr. Wong and Dr. Puri. I'm going to be a little more clinical on this talk, give a little overview of giant cell tumor, and then discuss some of the challenging cases we've treated here at the University of Florida. Standard histopathology slide, as you can see, a large giant cell tumor with those stromal cells that Dr. Wong discussed, which has the neoplastic properties of this tumor. So as we most know, it usually occurs in the 2nd to 4th decade of life. Equivalent in men and women, a little more seen in women, but otherwise it's metaphyseal and epiphyseal. And it's most commonly found about the knee, usually about over 60% of the time, either distal femur or proximal tibia. And obviously pelvis, sacrum, and spine has its own issues, as Dr. Puri had discussed. So pain is often presenting, sometimes with a mass, and if ignored long enough, these patients present with pathologic fractures. It's an interesting tumor, right? We call this a benign tumor. However, 3 to 5% of these can actually metastasize to the lung, and it does have some locally aggressive properties, and we can also see multicentricity. Some of these patients present with synchronous disease. So at the time of diagnosis, we usually get a bone scan to make sure that there's no other sites, and even metachronous disease, which is further down the road. And I'll show some examples of that. And as discussed previously, there is some anecdotal evidence of this rare malignant sarcomatous transformation. When you look at it under the microscope, the giant cells are diffusely and evenly distributed. You have these mononuclear stromal cells, which we saw a lot of pictures of before. The nuclei of the mononuclear cells and the giant cells look very similar, which is kind of diagnostic for our pathologists. These giant cells can have over 50 nuclei. From a pathologic standpoint, you can see hemorrhage and necrosis, as well as mitotic figures in these specimens. And so when you do your frozen, sometimes the pathologists tell us to stop because they do have some concerns. I think it's nice to look at history a little bit. In the past, these tumors were treated incredibly aggressively with sometimes even ablative type procedures. They were considered potentially malignant at that time. And, you know, Dr. Enneking came to the University of Florida in 1960. And back then, he had very limited options, right? So they didn't have allograft tissue banks. They didn't have endoprosthetics. And so I kind of contributed to this idea of limb salvage in the treatment of bone tumors, both malignancies and giant cell tumors. This is an article he published in 1977 where he proposed a resection arthrodesis using autogenous bone grafting about the knee. With giant cell tumors being so prevalent around the knee, ultimately, a lot of the patients that he treated with this ended up undergoing this procedure for giant cell tumor. So you can see some of the cartoon renditions there on the left, the drawings where you have a distal femur and he would do a tibial turn up and use ipsilateral tibia or a femoral turn down. Some of the radiographic examples there on the right, and that was the fusion nail that he would use, which was made out of stainless steel and was fluted. I've actually had to take one of them out. I'll show you an example of that. It's very, very challenging. Here's more cartoon or drawings of his procedure. He would resect the proximal tibia in this situation and do what's called the femoral turn down, and then harvest ipsilateral fibula, as well as the tibial turn up. So he does a hemicortical autogenous graft from the tibia, moves it up to fill the void, and then grabs the fibula and brings it up as well. It's non-vascularized and places the fusion nail. So just this past week, I actually saw this patient in clinic. Back in 1979, Dr. Enneking did a resection of his proximal tibia with an autograft fibula and femoral turn down. Here were his x-rays. I joined the faculty here in 2014, and one of the awesome things about being at the University of Florida is I can see patients like this that have been around for decades. And this guy was treated by Dr. Enneking in 1979. You can see here the surgery that he performed, and he came in and he was actually doing pretty well. This is a CT that was done in 2011 that shows the fusion mass and the rod in place. Unfortunately, like all things, nothing ruins good outcomes like follow-up. And so he sustained this injury and presented with pain, inability to bear weight. We had to remove this nail, which took about 4.5 hours, 2 fellows, 3 attendings, and we placed another fusion nail and used RIA from the contralateral femur for bone grafting. And now it's 2021, so he's 42 years out and doing okay. So today, you know, due to the morbidity of resection and reconstruction and the ability to achieve relatively good rates of local control with extended curettage and adjuvants, that's usually the treatment of choice when possible. Adjuvants include phenol, liquid nitrogen, argon beam. It's just trying to extend the kill zone. We use argon beam here. I know Dr. Lewis is on the call. She did a publication with argon beam and giant cell tumors back in 2006 in core, and they had good local control with recurrences less than 10%. Cementation is a preference for me, just given the fact that it's early stability, easy to identify local recurrences, and I'll show an example of some bone substitute that was used, difficult to see the local recurrence. And there's some theoretical advantage given while the cement is hardening, it's an exothermic reaction, which can have thermal and chemical necrosis. So this is actually courtesy of Dr. New. This is in Jesuitan Hospital. You can see the argon beam coagulator using to extend the adjuvant for the cavity where the giant cell tumor was. And so the other thing we do also sometimes is we will actually use a little bit of bone graft in the subchondral region to improve the weight mechanics of the area and minimize risk for degenerative changes. Radiation therapy, which was discussed previously in one of Dr. Puri's slide, it's not standard, but sometimes needed, especially in tumors that we are unable to resect due to the morbidity. Sometimes patients with multi-centric disease and repeat local recurrence. Lung metastasis, often we recommend metastectomy when possible, if it's oligometastatic or isolated lesions. Obviously, with widespread disease, usually we get into the topic of denosumab and bisphosphonates, which was discussed rather eloquently earlier today. This is a kind of a drawing rendition of kind of what the surgery is like. You have the top left, do a corticotomy, do a biopsy, then you do an extensive corticotomy with burring. At this point, you use the adjuvant. Bottom left is where they place a little bit of subchondral bone graft to protect the joint and cementation. You can see this was done before the advent of universal precautions because the surgeon's not wearing gloves. This is a recent case, kind of to show the example of when you use bone grafting. This is a young woman that presented after moving to Giansville. She was clinically asymptomatic. She'd been treated at an outside institution a year prior. Here's her imaging before. She was treated at the outside institution. You can see she has a giant cell tumor of her lateral femoral condyle, and they used a bone substitute to fill the defect. She was clinically doing great when I saw her. These are her first x-rays that I obtained. It was about a year post-op, and there was some radiolucencies around the bone graft. The issue is it's sort of a natural process. There's some cystic degeneration, some incorporation, and so it was really difficult to tell whether or not she had a local recurrence. We obtained an MRI, which showed mainly cystic degeneration, and opted to continue watching her given she was clinically asymptomatic. Continued to follow her, and then about 2 years post-op, this started happening. And so you can see we got an MRI, and she has a local recurrence, which we hadn't picked up previously. So hard to tell whether it was already there a year after, but obviously this is a significantly more morbid type surgery for her. When we did the biopsy, actually, there was some concern for malignant transformation, so we ended up having to stop. The nice thing is there's a mutation, a histone mutation that's present in over 90% of GCTs, which is the H3F3A, which was positive in her case, and then we were able to proceed with extended curettage and ultimately cementation, subchondral bone grafting, and plate fixation, which is what we would classically do. So in my eyes, denosumab, obviously we've discussed this quite a bit. I think it's great for solidifying tumors that have a significant soft tissue component. As Dr. Wong had mentioned, it can make intralesional surgery pretty difficult. I think it's great, the idea of using navigation potentially to help with your margin. My first few local recurrences was when denosumab was hot off the press. And I ended up going in and really had a difficult time assessing the margin because obviously the consistency becomes fibrotic. It's known to have some higher local recurrence rate at times. I think the main thing I learned, I did travel to Birmingham at some point, and the discussion they had with denosumab there was that you really shouldn't change your surgical plan going in. You shouldn't downstage the disease by using denosumab at this point. This is a case to show that denosumab was used, I think, elegantly. She had a scapular mass. She was actually already started on denosumab by the time she got to me. She was there just for a surgical evaluation. She has this scapular giant cell tumor. And you can see on the left is before, and you can see the soft tissue aspect of the tumor, but you can't really notice where the tumor is. And then after denosumab, you can see how it kind of nicely mineralized and allowed us to improve our overall margin. This is pre and post CT scans of the same tumor. The left side is the soft tissue windows, but you can't really see it on the bone windows, which is why I didn't use it there. This is a pre-op MRI, and then ultimately we did a resection of this one, and she did quite well. Interestingly enough, we get chest X-rays yearly on these patients, and you can see there the chest X-ray on the left. She started showing some nodules, and unfortunately, chest CT she had widespread mets. So this patient was started on denosumab and was doing well, and then 2 years post-op, for some odd reason, she started developing certain lesions had stayed stable. And gotten better, and some were getting bigger, and we weren't sure what was going on. So she actually was seen by the thoracic surgeons who removed these lesions, hoping that it wasn't some sort of misdiagnosis or some malignant transformation. But what we found was in the path was that these were giant cell tumors that had no treatment effect, which didn't make a lot of sense. While this patient was treated by an outside oncologist, she had changed jobs, her insurance had changed, and then denosumab was no longer covered. So she actually was started on zoledronic acid. So it kind of goes to show what we had discussed previously, that the mechanism of action of these two are very different. And I'm not sure exactly what the role is in pulmonary metastasis, but this patient was put back on denosumab and she's now clinically doing fine. The last case is a case that is kind of the gift that keeps on giving. This poor young gentleman in 2011, Dr. Scarborough, my partner, treated him. He had a curettage, adjuvant, and allograft for this GCT of his left fourth metacarpal. Here's his imaging. And they did this surgery. I guess all they really had left was periosteum, and kind of brought the metacarpal head over this allograft fibula, and were able to reconstruct his metacarpal. At a year post-op, he developed this local recurrence and ended up with a ray resection. And ultimately, he developed pulmonary metastasis in 2014. So this is 3 years later. Ended up undergoing a wedge resection. And this was before denosumab was just starting to come into play. And then he presented in 2015 with right hip pain, and has this lesion. Underwent a extensive curettage, bone grafting, fibular strut, and DHS application. And then on bone scan, he was noted to have lesions at T10, as well as the left ischium. Here's his ischial lesion. So he was started on denosumab on December of 2015. Was continued on denosumab, and then subsequently started having progressive left hip pain. So now you can see there's a lesion in the left acetabulum. Here's the lesion. He ultimately underwent a curettage and bone grafting of the left supraacetabular region, and was doing well from that. He was on denosumab monthly for almost 2 years, and they decided to move him. And I know the dosing is always kind of in question, but the medical oncologist changed him to Q3 months, and that went on for about a year until he started developing left hip pain now. And this is actually back in January. So the treatment for him is going to be radiation, back on monthly denosumab, and to see how he does. So this is a algorithm that was published by the group in Leiden with Michiel and Sander, which I think is pretty spot on to how I try and manage these. I think the important concept here is that this is a multidisciplinary approach. You need medical oncology, sometimes radiation oncology, and obviously on the patients that have local recurrences or inoperable disease, you have to use all the tools in your armamentarium. So in conclusion, previously treated very aggressively, but obviously with these resection and morbid procedures, current treatments are extended curettage and adjuvants when possible. DMAB is a nice adjunct, and I think in certain cases, as Dr. Puri had mentioned, is very indicated, but it should not be used to downstage your surgery. In complicated cases with unusual behaviors and pulmonary mets, usually require a multidisciplinary approach. Thank you. Any questions would be welcome.
Yeah, we do have one question from the audience, from Dr. Nicholas Castles. The question is, when do you use plate fixation with bone cement?
When do you use plate fixation with bone cement? I typically, so first, distal femur, I do. There's varying techniques. You can, sometimes when you have a pathologic fracture through the distal femur, it's nice to get the cement in there and let it harden so it holds and stabilizes your fracture, so you can drill through the cement. It's nice not to drill through the cement, so sometimes you can fix the plate proximally with 2 screws and kind of rotate it out of the way. It really depends. But typically around the knee, I try and use cement when I can. In the proximal femur, I find myself more often using bone grafting. And it's just, I think it's preference and kind of difficulty of using cement in that location.
Do you have any experience using zoledronic acid impregnated bone cement for your giant cell tumors?
Yeah, it's a great point. I personally don't. I know, Dr. Greenberg and Fran have a study that's out there. Have you done it, Val? I haven't done it.
I have not either done it.
Yeah. So I know there's a group that has a multi-institutional trial that are looking at that, and I think the main reason they used Zometa was because of the properties right? I think denosumab maybe doesn't work so well when the exothermic reaction is present. So I think they've proven that Zometa does. And so it doesn't, but I have zero experience with it. We'll see what their results show.
Absolutely. That was a question from Dr. Rotor. So, we did have a question to all panelists and kind of probably also to Dr. Puri related to his lectures. It says, will you regret using, it just clicked off. In sacral curettage, consolidated giant cell tumor of the sacrum with denosumab. What is your experience with the sacral nerve roots?
I think that's Casey's response to somebody asked a question whether we have experience in curettage of the sacrum and regarding the nerve roots. And I said, we have no experience. And I think Casey has been much stronger than me. I was saying that you will regret if you ever try a curettage.
Yes, especially for, yes.
Go ahead.
Yes, especially for the well-consolidated denosumab. Let's say you got a sacral GCT in 6 months. They actually is hardened like a bone there. You are impossible to separate the nerve from the tumor tissue. So you really consider curettage of a sacral lesion, and also if you really want to use denosumab to, let's say, to decrease the blood loss because of decreased angiogenesis of these tumors, you better give 1 or 2 doses, and you quickly do within the 4 to 6 weeks. Otherwise, once the tumor hardens, you're not possible to separate the tumor tissue from the nerve root.
Great, thank you very much. And this is a question, I'm assuming to Dr. Spiguel. Do you think that Enneking had less recurrences because he was more aggressive in his resections?
Yeah, I think Dr. E, at the time, they weren't 100% sure of this is me, an educated guess, but they weren't, these were considered potentially malignant lesions. So I think he probably was more aggressive. And even for us, right, when you have these like stage 3 lesions and you do something, it's really destructive. If you do a resection and reconstruction, the local recurrence rates can be less than 10%. Whereas we're typically dealing with 1 in 5 when we do these extended curetages. So it always, it begs the question, right? This is a benign tumor, and are we under treating it or over treating it? I think we're kind of at the sweet spot. I think, obviously you are having increased risk. These are young patients, and so if you can preserve their function, I think it's acceptable to do so.
Sounds good. And we have another, or maybe the final question to all the panelists. And Andre, you kind of touched on this, but when do you prefer bone graft versus cement? Or is it purely personal preference?
Yeah.
And that's to all the panelists.
I prefer cement just because it's easier to follow. I think I've had a few in the proximal femur. I feel like the next step, if it's really extensive, is going to be some sort of arthroplasty. And I just feel like it would be, I try and preserve as much bone stock as I can. So I tend to bone graft up there. But I do prefer cement for the reasons that I had mentioned previously, when possible. In younger patients, sometimes I'll choose bone graft. I think it's kind of experience specific. I don't know if the other panelists have any other preference.
Dr. Wong, Dr. Puri, do you have any other preference?
I always use, yes, maybe.
Sorry, Casey, go ahead.
Maybe Professor Puri, you can make the comment first.
No, I agree with what Andre said. So theoretically, yes, in younger patients, we would all prefer bone, but sometimes the size and nature of the cavity is so large that you go in for cement, especially if it's something like a ping pong cartilage where the cartilage would sort of give way and you've really done a very aggressive curettage. The borderline salvable cases, we'd go in for cement. But a young patient, 25, 30, 35 odd, we would prefer bone if available.
Great. Dr. Newey, do you have a comment on that?
Yeah, I prefer to use bone cement. I mean, everywhere except the femur head.
Yeah, me too.
So as much as possible. Thank you.
I'm with you, Dr. New.
Awesome. And then we have one final question because it's 7:58 here in, actually, I don't even know what time zone I'm in, but we're near the end of the webinar. And the final question is to the whole panel. For pulmonary giant cell tumor, what is your usual regimen using denosumab?
All right,
I defer to our medical oncologist. They usually do monthly for a while, and they try and go to every 3 months after about a year. That's just been
And
my
how long
experience.
do you continue after that year?
Yeah, I don't think anyone knows the answer. Casey, do you have any? We usually go for as long as we can.
We have been treating some case of primary metastasis just using denosumab. I think theoretically, if the primary metastasis can be resectable, it's still probably ask the cardiothoracic surgeon to resect it. Because all this drug is just controlling the tumors. Once you stop it, you go back in. But there should be some time point to decide to decrease the side effect. Especially, let's say in one of our previous patients, they got some dental problem. They need to stop the drugs for 3 to 4 months. Once they stop it, they go again. So at the moment, we still don't have the end point. So that, if possible, if it is still resectable from the cardiothoracic point of view, I think it's still advisable to resect it if possible.
What's the longest that you have had a patient on denosumab? That's a question for the whole panel.
So
one of the patients with primary metastasis is 6 to 7 years.
Yeah.
6 or 7 years.
Yeah.
And this patient that I presented, he's been on it since 2014. So keep going. We have another patient that was on for a long time who ended up with osteonecrosis, so he had to stop.
Dr. Puri, I see you were trying to respond.
Yeah, I said in India, we had denosumab made available much later than it was to the rest of the world and so we've had one for about 4.5 years, but it's the pulmonary one. We've never had any extremity or other one that we've had on long-term denosumab. And one of the possible reasons is cost, because patients have to pay out of pocket and it's pretty expensive out here.
Yes, absolutely. Well, I think that's the last question. On behalf of the Education Committee and ISOLS, I want to thank all the speakers and participants. This was a wonderful webinar. And I guess we want to remind everyone to please join in with us next month when we have Professor Weingarten talking about megaprosthesis reconstruction and revision. Thank you all very much.
Thank you all. Bye-bye.
Everybody.
Stay safe.
Thank you.
Wonderful lectures.
Bye, Professor New. Bye, Hairong. Thank you for having me.
Thank you, Professor Puri. Thank you, Casey Wong.
Thank you. Thank you very much.
Everybody.
Thank you, AJ. Bye.
Bye-bye. Thank you.
Juan, I'll talk to you on Thursday. And Hairong, talk to you on Thursday at our meeting.
Yeah, see you on Thursday. Bye-bye.
Great